Anxiety and insomnia have been part of the human experience for thousands of years. Early on, people turned to alcohol as a means to ease these distressing symptoms. While alcohol provided some relief, it was never a perfect solution. Its effectiveness is limited and it comes with significant risks. What's important to note is that these conditions are not only persistent but have become even more prevalent in recent times, especially during the COVID-19 pandemic. This historical perspective helps us understand the ongoing challenge of managing anxiety and insomnia, and it sets the foundation for exploring more advanced chemical treatments developed over time. Here we see some of the earliest medical treatments for anxiety and insomnia. Starting with chloral hydrate, introduced around 1870, it was effective in inducing sleep within an hour, and the effect lasted between 8 to 11 hours. However, it wasn't without significant drawbacks, such as stomach irritation and a high risk of addiction. Next, formaldehyde came into use in 1882 as a hypnotic. One of its advantages was causing little depression to the heart, but it had a very unpleasant taste and a strong odor on the breath, which limited its widespread acceptance. Finally, bromide salts were introduced in the mid-1800s and used as sedatives. Although effective, they accumulated quickly in the body, leading to depression, and had a narrow therapeutic window. They were eventually replaced due to severe withdrawal symptoms and safety concerns. These early treatments were important stepping stones that helped guide the development of safer and more effective medications for anxiety and insomnia in the future. Here we see the timeline of barbiturate production from its discovery all the way through the late 20th century. Barbituric acid was first discovered in 1864 by Adolphe von Baeyer, but it wasn't until 1903 that barbitol, the first barbiturate drug, was developed. The chart shows a rapid increase in production as barbiturates quickly became the leading sedative hypnotic medication, especially in the early to mid-1900s. Production peaked around 1950, exceeding 1 million pounds annually in the US alone. This surge was driven by extensive chemical research, resulting in thousands of barbiturate compounds, although only a few were actually used clinically. Starting in the 1960s, we notice a significant decline in production, which corresponds with the rise of benzodiazepines. These newer drugs were considered safer and more effective, leading to a decrease in the medical use of barbiturates over time. Here, we see how barbiturates affect the central nervous system by enhancing GABA activity, which slows down neural activity and produces sedation. The chart breaks down barbiturates into 4 categories based on how long their effects last: ultra-short, short, intermediate, and long-acting. One important point to note is the inverse relationship between lipid solubility and duration of action. Barbiturates that are more lipid-soluble act quickly and are more potent, but their effects wear off faster. On the other hand, those with lower lipid solubility have a longer duration. This distinction is crucial because it determines the clinical use of each type. For example, ultra-short barbiturates are ideal for inducing anesthesia for brief procedures, while longer-acting ones are better suited for ongoing seizure control or sedation. Understanding these categories helps us tailor treatment to the specific needs of each patient. Here we see the primary clinical effects of barbiturates when taken at therapeutic or normal doses. First, barbiturates induce relaxation and can produce a feeling of euphoria that's somewhat similar to what you might experience with alcohol. This contributes to their use as sedatives. Speaking of sedation, they do cause drowsiness, but interestingly, they also disrupt normal sleep patterns by significantly reducing REM sleep, which is essential for restorative rest. This disruption can impair overall sleep quality. Another important point is that barbiturates tend to accumulate in body tissues, which means that even after their immediate effects wear off, users can experience a kind of drug-induced hangover. This hangover involves prolonged psychomotor impairment, so their impact lasts longer than you might initially expect. Recognizing these effects helps us understand both the therapeutic benefits and potential drawbacks of barbiturate use. Barbiturate use comes with several serious complications and side effects that we need to be aware of. Commonly, users experience nausea, dizziness, and a general slowing of mental processes, which can impact daily functioning. Another important issue is photosensitivity, where individuals become extremely sensitive to sunlight, raising their risk of sunburn. Interestingly, barbiturates can also cause paradoxical rage reactions, which means some users may exhibit unexpected aggressive behavior due to neuronal interference. Sexual dysfunction is another significant side effect, with many users reporting problems like reduced libido and impaired sexual performance. When it comes to sleep, although barbiturates are used as hypnotics, tolerance develops quickly, and the sleep produced is abnormal with a reduction in REM sleep, which is crucial for restorative rest. This can lead to rebound effects once the drug is stopped. Perhaps most critically, barbiturates have a very narrow therapeutic window. The dose that produces the desired therapeutic effect is close to the lethal dose, which significantly increases the risk of overdose, especially as tolerance builds. Because of these risks, careful monitoring of patients using barbiturates is essential to ensure their safety. On this slide, we focus on the critical drug interactions involving barbiturates. First, barbiturates can intensify the effects of several central nervous system depressants like alcohol, narcotic analgesics, benzodiazepines, and antihistamines. This increased CNS depression can lead to dangerous sedation or even respiratory problems. Next, when barbiturates are taken with monoamine oxidase inhibitors, the breakdown of barbiturates is blocked, which raises their levels in the body and increases the risk of overdose, so close medical supervision is essential. Barbiturates also speed up the metabolism of important medications such as certain antibiotics, antidepressants, oral contraceptives, corticosteroids, warfarin, and metronidazole, potentially reducing how effective these drugs are. Moreover, combining barbiturates with acetaminophen significantly increases the risk of liver damage. Given these serious interactions, it's vital that barbiturates are only used alongside other medications under strict physician guidance to ensure patient safety. When someone takes more barbiturates than prescribed, they can start showing symptoms like slurred speech and loss of coordination, much like being intoxicated with alcohol. One of the most dangerous effects is that these drugs depress the respiratory centers in the brainstem, which control breathing. As the dose increases, this can lead to serious breathing difficulties, even respiratory arrest. Additionally, barbiturates suppress the cough reflex, which raises the risk of lung infections like pneumonia and bronchitis. Unfortunately, there isn't a specific antidote to reverse an overdose, so it's absolutely critical to seek immediate medical attention. Prompt treatment can make all the difference in preventing severe complications or death. As we look at the timeline here, we start with continuous use and neuroadaptation. The body quickly adapts to barbiturates, which leads to tolerance of their sedative effects after a relatively short period. However, this tolerance is specific. While users become tolerant to the sedative and hypnotic effects, the lethal effects do not diminish. This means that the risk of overdose remains just as dangerous, which is a critical point to keep in mind. Moving on, withdrawal symptoms usually begin to appear around 2 to 3 days after stopping the drug. These symptoms can be severe, including confusion, seizures, and delirium tremens, like states, which reflect the neurological impact of withdrawal. Withdrawal itself is very serious. It can last anywhere from 3 to 14 days and is potentially life-threatening. Because of this, withdrawal must be medically supervised to manage the severity and ensure the patient's safety. Close monitoring and professional care are essential to prevent complications and support a safe recovery during this challenging period. Here we have a look at barbiturate-like drugs that emerged after World War II, initially touted as safer alternatives to traditional barbiturates. Starting with glutathione, introduced in the 1950s, it unfortunately shares many of the same risks as barbiturates, including serious withdrawal symptoms like convulsions and fever. Next, meprobamate was quite popular in the 1950s as a non-barbiturate anxiolytic and hypnotic, but it also carried a significant potential for addiction and is rarely prescribed today. Moving on to methaqualone, it was offered in the 1960s as a seemingly safe substitute. However, it was quickly found to cause euphoria and tolerance. Due to widespread misuse, it is now classified as a Schedule I drug and banned in the United States. Lastly, ethchlorvanol and methylprednisolone are related compounds that carry misuse risks as well. Ethchlorvanol, in particular, has been linked to vision loss after prolonged use and is rarely used currently. Altogether, These drugs highlight the ongoing challenges in developing anxiolytic and hypnotic medications that are both effective and safe. This slide presents the DSM-5-TR classification and summary of barbiturate use disorders. First, the classification categories include use disorder, intoxication, withdrawal, induced mental disorders, and unspecified barbiturate-related disorders. The diagnostic criteria require the presence of at least 2 symptoms within a 12-month period, such as tolerance or withdrawal, but importantly, this excludes use under prescribed medical supervision. Withdrawal symptoms are a critical concern because they can be severe and even life-threatening, so medical supervision is essential during this phase. Diagnosing these disorders can be complex due to symptoms like rebound anxiety, which may mask or mimic other conditions. Overall, barbiturate-related disorders encompass misuse, intoxication, withdrawal, and significant impacts on mental health, making careful assessment and treatment vital.